So in part C of Chapter 8, I want to talk about some of the caveats for using left ventricular output as a marker of fluid responsiveness. And I want to talk about some of the caveats even as it applies to patients who are heavily sedated and potentially paralyzed and who are receiving 8 cc's per kilogram tidal volume ventilation, because these were the patients in which the pulse pressure variations and systolic pressure variation were initially derived as markers of volume responsiveness. And we'll get into some of the physiology of why some patients may have pulse pressure variation and may not be volume responsive, and again that would be false positives or a degraded specificity, or why patients may not have pulse pressure variation and may still be fluid positive, and that would be false negatives or a degraded sensitivity. And the reasoning will come that you'll come to realize is that changes in intrathoracic pressure, first of all, are variable amongst different groups of patients, and changes in intrathoracic pressure and changes in airway pressure can actually induce changes in biventricular function that are unrelated to volume responsiveness. And as you saw probably in part B, that the change in intrathoracic pressure is assumed to preload reduce the right ventricle, and therefore the preload reduction will induce a decrease in right ventricular output and a change in your left ventricular output a few beats later. But what if the change in airway pressure, the change in lung volume and intrathoracic pressure, what if that induced a change in right ventricular afterload, or induced a change in left ventricular afterload, or left ventricular compliance? And all of these things may actually induce changes in left ventricular output that are unrelated to volume responsiveness, and that would further degrade the specificity or yield false positives of there being pulse pressure variation and systolic pressure variation, and the patient is actually truly not volume responsive. We're going to get into that over the next few slides. So as I mentioned, there's this idea of specificity. So both the D up, or the maximal pulse pressure, and the D down, or minimal pulse pressure, may result from respiratory variation cardiac physiology that does not, I repeat, does not reflect preload responsiveness. And as you may have realized, the cardiac function curves shift in parallel to systemic venous return or pulmonary venous return, but their slope can also shift. And when the slope shifts, you may actually get changes in cardiac output that do not reflect preload responsiveness, but actually may reflect changes in the diastolic properties of the heart, or the afterload, or the afterload properties of the heart, which can very easily be induced by changes in intrathoracic pressure. So changes in afterload and compliance are more likely to result in false positive pulse pressure and stroke volume variation when the ventricles are sensitive to afterload, so in heart failure states, or when intrathoracic pressure is excessively high, for example, high tidal volume or low chest wall compliance. So this slide we'll talk about the facilitation of D up. So what are some situations where you might have an inappropriately facilitated D up? That is, you see a D up which will increase your pulse pressure variation or your systolic pressure variation, and the patient is not actually truly volume responsive. So again, this, just for review, this is your apneic baseline, this is your maximal systolic pressure, your maximum pulse pressure, and this is your D up. So these are the mechanisms that we talked about that lead to D up, or your maximal pulse pressure, in part B of this chapter. So really an augmentation of any of these effects can occur in a patient who's not actually volume responsive. So if there's an excessively large intrathoracic pressure change, for example, somebody with very high lung volumes or very poor chest wall compliance, if somebody was being ventilated with 15 cc's per kilogram tidal volume, which I'm not sure why that would occur, but if that did occur, that could induce excessively large changes in intrathoracic pressure. It could give you D up, even if the patient's not volume responsive. Decreasing left ventricular afterload as a result of the increased intrathoracic pressure, certainly that could occur, but that would be in patients who are typically have poor cardiac contractility in heart failure states. Improved left ventricular compliance. So if the patient were, say, in right heart failure and had a dilated right heart and received a positive pressure breath, and that caused the right heart to shrink and therefore improve left ventricular filling during inspiration. That may actually improve LV output during inspiration and therefore lead to a D-up that may be inappropriate. And then increased pulmonary venous return. So if a patient has waterlogged lungs and they have an excessively high fraction of West Zone 3 physiology, as you increase your transpulmonary pressure, as you increase your lung volume, you will augment pulmonary venous flow, and you'll actually preload the left ventricle during inspiration. So that too could lead to an inappropriate D-up in a patient who's volume responsive. So I want to get into this idea of intrathoracic pressure a little bit more as an important caveat, because in a lot of these initial studies that looked at pulse pressure variation and systolic pressure variation, the patients had normal chest wall compliance and therefore essentially normal and consistent changes in intrathoracic pressure as a function of tidal volume. So in the fully adapted or fully passive or not, a patient who's not generating inspiratory expiratory efforts, the patient receiving mechanical ventilation, the intrathoracic pressure is dependent upon the tidal volume and the chest wall compliance, and it's roughly related by this equation here. Intrathoracic pressure is directly related to the tidal volume change, and it's inversely related to chest wall compliance. So you can note that pulmonary compliance is actually not part of the equation. Pulmonary compliance is related to this in that the pulmonary compliance actually determines your tidal volume in a patient who's receiving mechanical ventilation. If a patient has a very poor pulmonary compliance, that is stiff lungs that don't want to distend, and you give them high volumes, well, the high volumes will result in high airway pressures and high transpulmonary pressures, but the tidal or the volume of the lung, this should actually really be lung volume, the volume of the lung will be small because of the poor pulmonary compliance, and therefore the change in the intrathoracic pressure will be minimal or less. And I'm going to illustrate this with a cartoon in the next slide. This physiology has been explained with the modified Campbell diagram in part A of this chapter, and certainly in chapter 4 I talk a lot about chest wall compliance and intrathoracic pressure. But if you want to review, you can go back and review the final slide of part A of this chapter. So how does pulmonary compliance and chest wall compliance relate to intrathoracic pressure? We'll consider this silly little cartoon that I've drawn up for you. So these are 3 lungs, and I want you to think of them as like a balloon in a box, and this is a machine that's going to deliver each of them the same volume. This we'll call normal. There's a normal, the balloon is the lung. This is a normal pulmonary compliance. The box is the thorax. It's a normal thoracic compliance. So it's the two of them together. It's a normal respiratory system compliance. Now this lung here, the thorax is stiff and non-distensible. So the thorax is poorly compliant, low thoracic compliant. You take your pick. Massive obesity. This patient has a BMI of 85, which a patient of mine had in one of our ICUs recently. Massive ascites. Take your pick. Very poor stiff chest wall, but normal pulmonary compliance. And then this patient has very stiff lungs, right? It's an iron lung almost. You're not going to distend this lung, but the thoracic compliance is normal. So what you're going to do is you're going to give each of these systems the same volume, okay? So what's going to happen now that I've delivered the same volume to each of these? Well, what happens to the normal lung, okay? It's going to increase, and so too is the thoracic box, and there will be an increase in the intrathoracic pressure. So the intrathoracic pressure you could sort of think as the pressure between the balloon and the box. As the balloon presses out against the box, there's a normal increase in intrathoracic pressure like that. Okay? Well, what's going to happen in this situation when you give this normally compliant lung stiff thorax the same volume? Well, the lung's going to increase and push out against the stiff thorax and increase intrathoracic pressure to a much greater extent. And then so that's low chest wall compliance. What's going to happen in the situation where it's low pulmonary compliance but a normal chest wall compliance? Well, there's going to be a minimal increase in your volume, okay? And intrathoracic pressure, the pressure between the lung and the thorax, is going to increase minimally. So in this situation, the pressure that this machine, this is your ventilator, right? The pressure that's being driven into here is going to be much higher to achieve this volume, but it's because of the stiff box. In this situation, the driving pressure is going to be equally high. All right, this machine's going to have to work overdrive to push volume into here, but the intrathoracic pressure is actually going to increase minimally. The transpulmonary pressure and the plateau pressure will go way up, but that's because of the stiff lung, whereas this is going to have a normal driving pressure. So the important thing to consider here is that in functional hemodynamic monitoring, if the stressor that we're applying to the cardiovascular system is intrathoracic pressure, even if you're administering the same volume, same tidal volume to patients, 8 cc's per kilogram as it was derived, changes in thoracic compliance will lead to changes in intrathoracic pressure as compared to the original derivation group, and you'll have potentially more pronounced changes in cardiac loading conditions. Okay, so that was chest wall compliance is an important caveat when considering the effects of mechanical ventilation on the failing heart. So why is that? Well, imagine left ventricular and or biventricular failure. So the cardiac function curves are shifted down both for the LV and the RV. So this is the patient coming in with an alcoholic cardiomyopathy who's maybe septic and both of their ventricles are poorly functioning. If this patient also has a stiff chest wall, well then a given tidal volume that's given to this patient is going to result in a much more pronounced change in intrathoracic pressure. And this change in intrathoracic pressure may alter the cardiac function curves in ways that do not reflect preload responsiveness. So both you'll agree with me that this patient is not preload responsive. This patient is not volume responsive, right? They're on the plateau portion of both of their cardiac function curves. If you were to increase their mean systemic pressure by giving them a fluid challenge and increasing the venous return curve rightwards, and you intersect at a higher right atrial pressure here, you're not going to augment cardiac output at all. So this is a patient you would not want to give fluids to. But if this patient had an excessively high increase in intrathoracic pressure with the failing heart, they're going to be much more sensitive to the reduction in afterload. So the increase in the intrathoracic pressure during inspiration in this patient is going to lower your left ventricular afterload, which can augment left ventricular output without having anything to do with preload responsiveness. It's a function of shifting the cardiac function curve up and to the left as a result of decreasing the transmural wall stress of the left ventricle. So you've actually increased this patient's output as a function of the high intrathoracic pressure. Well, what else could happen in this patient? Well, that high intrathoracic pressure is going to be transmitted to the right ventricle as well. And remember, this is their transmural pressure for the RV. It's the intrathoracic pressure less the intramural, or the intraluminal pressure, I should say. That's the distending pressure of the right ventricle or right atrium is depicted by this line here. Well, the inspiratory breath, if it's an excessively high intrathoracic pressure, it may actually shift the cardiac function curve rightwards to a greater degree and actually may improve right ventricular afterload. Well, how would it improve right ventricular afterload as if you're giving a positive pressure breath? Well, you could make up some hand-waving ideas that if this patient was overloaded and they were hypoxemic and you improved their oxygen tension and mitigated pulmonary or hypoxic vasoconstriction, you could improve right ventricular afterload. I think probably the better explanation is improved right ventricular contractility as a result of systolic ventricular interdependence. That is, as you afterload the LV and you improve its contractile state, you'll actually improve the contractile state of the right ventricle because they share so many common muscle fibers. But nevertheless, the improved right ventricular afterload, the decrease in the right ventricular distension, is going to affect the left ventricle. How? Well, it actually might improve its compliance characteristics and shift its curve up even more. This is all during an inspiratory event, right? The increase in lung volume increases the pulmonary venous return as a function of West Zone 3 physiology, which will further augment your left ventricular output if the left ventricle is being intersected on its ascending portion. So you may actually, even as a function of increased LV preload in this patient, have an increase in your cardiac output. So you started down here before the inspiratory event, and now you're up here. So you may actually get a D up, particularly, and this is very sensitive or more common in patients with poor cardiac contractility, that you may actually get a false positive D up just by these improved afterload, improved compliance, and potentially increased left ventricular preload during a mechanical inspiration. So this is left ventricular and or biventricular failure. So this is when you get this improved D up. The way that you may be able to distinguish this patient is that they'll have minimal, if any, D down, because there's a minimal inspiratory decrement in right ventricular output. So if you see an arterial waveform with pulse pressure variation or systolic pressure variation, and you go in and you put your hand on the patient's chest, and you notice that every time there's an inspiration, there's a D up or an increase in their systolic pulse pressure, but there's very little D down, and the patient clinically is in heart failure. Again, this you have to always interpret these test results in terms of your pretest probability. Well, then the pulse pressure variation and the systolic pressure variation you're getting is probably a false positive. And this effect is sometimes referred to as the reverse pulsus paradoxus. That is the increase in left ventricular output with a positive or mechanical inspiratory breath. So the last slide we talked about potentially false positives with the D up, but you can actually have false positives of the D down. So what is the physiology that would facilitate a D down, particularly in the setting of a patient who is not volume responsive? So again, for review, this is your apneic baseline. This is your minimal systolic pressure that occurs a few cardiac cycles after inspiration is initiated, and this is your D down, and this is your minimal pulse pressure. Minimal pulse pressure. So it's the same mechanisms that create D down in the first place. These can be exaggerated and could occur in certain states where patients are not volume responsive at all. So there may be an excessively high drop in your intrathoracic pressure, which you could theoretically imagine in a patient with, a stiff chest wall and potentially lungs with high elastic recoil. During expiration, there may be an excessively large drop in your intrathoracic pressure. I'm reaching a bit, but it's potentially a mechanism to keep in mind. There's going to be an increase in your left ventricular afterload as intrathoracic pressure goes down. Again, this is going to be more of an effect in patients who have poor cardiac contractility. Similarly, decreased LV compliance as the right ventricle is charged with blood during expiration. As venous return increases to the right heart, you may impair left ventricular filling and left ventricular output. And then decreased pulmonary venous return. Remember again that the D down reflects a diminished right ventricular output from inspiration a few cardiac cycles previously. So you could imagine a clinical state where you have a right ventricle that is not volume responsive, but a mechanical inspiration actually induces a drop in right ventricular output, not because of a decrease in preload, but because of an increase in afterload. That's what I just said. So what about states of high right ventricular? And these aren't just, I'm not just making this stuff up. There's actually, in the last couple of years, there's been some neat papers in critical care medicine that have actually looked at patients with pulmonary hypertension and patients with severe pulmonary ARDS with very low presumed pulmonary compliance. This is a paper by, I forget the group now. I want to say it was Monet and colleagues, but I could be wrong. It was looking at a group of patients who had respiratory system compliance of much less than 30, which is a very low respiratory system compliance. They didn't drop an esophageal pressure balloon, so you weren't able to know exactly if the drop in respiratory system compliance was from pulmonary ARDS or extrapulmonary ARDS as classified by Gattinoni and colleagues in the Blue Journal in the late 90s. But I looked at the patients in that study, and almost all of them had ARDS or had a drop in the respiratory system compliance as a result of a direct pneumonia. So they probably did have pulmonary ARDS. So they probably had poor pulmonary compliance. And actually the specificity of pulse pressure variation broke down in that group almost completely. It was almost like flipping a coin. And presumably the mechanism was, and this is because of the high incidence of right heart failure that you see in severe ARDS, that the mechanical inspiration was actually dropping right ventricular forward flow, not as a function of decreased right ventricular preload, but as a function of increased right ventricular afterload, which is what I'm going to demonstrate here. So the reduction in right ventricular output as a response to an inspiratory increase in intrathoracic pressure may represent preload responsiveness, as we saw in part B of this chapter. And here it is here. So you've increased intrathoracic pressure and you've dropped your right ventricular preload and your right ventricular output. And this is a nice representation of the physiology of preload responsiveness. But imagine the patient that I just mentioned, the patient with severe pulmonary compliance or pulmonary arterial hypertension, patients who are going to be sensitive to increases in right ventricular afterload, and you give that patient a positive pressure breath, what might happen? Well, this patient could be volume overloaded, let's say. Their venous return curve is shifted rightward. They're very close to the plateau portion of the right ventricular function curve. So for argument's sake, let's say that this particular patient is volume non-responsive. That is, if I bolus this patient, they would not augment their cardiac output. And you give this patient an 8 cc per kilogram tidal volume, and you have a large decrement in output because of an increase in right ventricular afterload. So look at the difference here. The positive pressure breath will shift the right ventricular cardiac function curve rightward because of the increase in intrathoracic pressure, increase in pleural pressure, but the increase in transpulmonary pressure, that is the increase in the difference between your alveolar pressure and your pleural pressure, goes way up because of the poor pulmonary compliance, and that afterloads the RV. So you have this dramatic shift down into the right of the right ventricle, and now you have this drop in your right ventricular output. 2 to 3 cardiac cycles later, you would have a pronounced D down, and it's not because this patient is operating on the ascending portion of their Starling curve. It's actually because the mechanical breath itself induced an abrupt increase in right ventricular afterload. And again, this is stuff that is a clinical reality. This is not just me pontificating. So the drop in RV output may result in a drop in the LV output a few cardiac cycles later and yield a D down, but this is not because of preload responsiveness. This physiology degrades the specificity of LV output variation. That is, it increases the number of false positives. What about excessive preload reduction? Well, we've kind of talked about this physiology a little bit already. The reduction in RV output is a response to it could represent preload responsiveness, as we saw. This rehash of the physiology we know. Okay. Or it could result from excessive inspiratory increase in intrathoracic pressure. So this could occur in the setting of very high tidal volumes or low chest wall compliance. So This patient, we'll say for argument's sake, is not preload responsive. If I give them more fluids, they're not going to have a significant increase in their cardiac output with volume. But you have a large increase in intrathoracic pressure for the same tidal volume. That would be the patient with the stiff chest wall. This patient is going to have a D down, but it is not because they are preload responsive. It's because in this patient, the poor chest wall compliance, that is the excessive increase in intrathoracic pressure, will cause an excessive drop in RV output and therefore give you a false positive pulse pressure variation. So chest wall compliance and volume responsiveness, just building on that previous slide, this was talked a little bit about already in the first part, part A of this chapter, but repetition is good. So again, this is the Campbell diagram. It is on an axis going into the page. So this is your x-axis. This represents pressure, intrathoracic pressure, pleural pressure, whatever you want to call it. And then the z-axis into the page represents thoracic volume. This is your pulmonary elastance curve. This is your chest wall elastance curve when there's no inspiratory or expiratory activity. And this is a given tidal volume that you're trying to achieve with the mechanical ventilator. So the administration of the mechanical breath to the certain tidal volume causes the intrathoracic pressure to rise along the chest wall compliance curve. Remember, in the passive, fully adapted patient with the ventilator making no inspiratory or expiratory efforts, the change in pleural pressure or the change in intrathoracic pressure is a function of two things: the tidal volume and the chest wall compliance. So for this breath, your intrathoracic pressure or pleural pressure would move from here at FRC to here at your new tidal volume. Okay? But imagine the patient has a severely reduced chest wall compliance. Massive ascites, obesity, take your pick. The same volume, the same tidal volume, is going to increase your intrathoracic pressure. Instead of going to here, right, it's going from here at FRC during this breath to here in the patient with the normal chest wall compliance. In the patient with the poor chest wall compliance, you're going from here all the way out to, say, here, right? Much greater increase in intrathoracic pressure. So this is the patient with that we saw a few slides ago with the poorly compliant chest wall, the stiff chest wall, but the pulmonary compliance may be normal. So as you inflate that balloon in the box, the balloon's going to press out against that stiff wall and increase the pressure between the two of them to a much greater extent. So now if we look at this in terms of superimposing the Guyton analysis and the Campbell analysis, so now on the x-axis you have right atrial pressure. You still have cardiac output now on the y-axis. Again, the z-axis is thoracic volume, and they share the pressure axis. You give the patient with a normal chest wall compliance the same 8 cc per kilogram tidal volume breath. Well, this patient's not going to have a D down, right? There will be no drop in your right ventricular output, and 2 to 3 cardiac cycles later during expiration, there will not be a drop in your pulse pressure or your systolic pressure minimum. There will be no D down. This patient will be a true positive and accurately assessed to be volume non-responsive. But the same mechanical breath in a patient with a poor chest wall compliance will do what? Well, you increase the intrathoracic pressure to a much greater extent. Even though you're giving them the same 8 cc's per kilogram, you've increased that stressor on the cardiovascular system. The intrathoracic pressure has gone up to a much greater degree. You shifted that cardiac function curve way over to the right relative to systemic venous return, and you've significantly dropped your output. This patient will have a D down and will be inappropriately labeled as being fluid responsive. So this is a false positive or degraded specificity. By similar reasoning, you can argue why left ventricular stroke volume variation may have an impaired sensitivity. Because stroke volume variation and pulse pressure variation parameters were derived in a very specific group of patients receiving 8 to 10 cc's per kilogram of tidal volume, the sensitivity of pulse pressure and stroke volume variation will be diminished if tidal volumes are smaller, because if you reduce the tidal volume, you may not induce the same change in intrathoracic pressure. You may not induce enough of a stress on the cardiovascular system, and you might not see any stroke volume variation. So a patient may be volume responsive, as I mentioned, but you may not detect this because of an insufficient change in intrathoracic pressure. So this is a patient now with, I've drawn them to have a poor pulmonary elastance. So this may be a patient with poor pulmonary compliance, say from ARDS. So this is shifted down and to the left, but they have a normal chest wall compliance, okay? Because this patient is ARDS, you're actually going to target a low volume ventilation. So instead of shooting for 8 to 10 cc's per kilogram, say way up here, you're going to shoot for maybe half that, or a little more than half that, like an ARDSNet protocol. And this will cause a very different change in your intrathoracic pressure. So it will go from here to here. So now your change in intrathoracic pressure is, again, pressure on the x-axis, volume on the z-axis into the page. Your change in intrathoracic pressure is only going from here to here. So you're minimally affecting the intrathoracic pressure change on the right ventricle. So that would be this situation with the stiff lung and the normal chest wall compliance. So as you give this patient a breath, there's a minimal increase in their pulmonary, in the volume of the lung, even though the driving pressure is going way up. The airway pressure will be going up as a function of the poor pulmonary compliance, but the intrathoracic pressure will be changing minimally. So if you superimpose this, or sorry, before we get to that, if we then do a modified Campbell analysis, so this is the elastance curve for the respiratory system, that is the lung and the chest wall together, it's bent down and to the right. So the airway pressure that you would see for this patient would go from here to here. So there'd be a higher airway pressure, and that would be simply a reflection of the poor pulmonary compliance. So if we superimpose this on the Guyton analysis now, this patient you could very easily see as volume responsive. Their operating point is actually subatmospheric. The right atrial pressure, again this is right atrial pressure on the x-axis, the right atrial pressure is subatmospheric, and your venous return curve is clearly intersecting the right heart function curve on its ascending or steep portion. So giving this patient volume would augment their cardiac output. But you are giving this patient this tiny breath, and the volume of the lung changes minimally because of the poor pulmonary compliance, that the change in the intrathoracic pressure may not be enough to stress the system. So you'll move from here to here, and you can see the cardiac output, the operating portion of the cardiovascular system has changed from there to there. So there's a minimal fluctuation in your RV output. You will not see a D down a few cardiac cycles later, and this patient will be deemed to be volume non-responsive, even though they clearly are. So that was it for the caveats of dynamic left ventricular output as measured by pulse pressure variation and systolic pressure variation in patients who are passive with the mechanical ventilator. And again, that is a group of patients who are passive, heavily sedated, potentially paralyzed, receiving 8 to 10 cc's per kilogram tidal volume with a normal chest wall compliance. You can see that there are certain clinical states, namely overload, right ventricular failure, excessive right ventricular afterload, poorly compliant chest walls that will degrade the sensitivity and specificity of pulse pressure variation and stroke volume variation. The next portion, we're ending at part C. We're moving on to part D. The next portion of chapter 8 will talk about pulse pressure variation in the spontaneously breathing patient. That is the patient who is receiving no mechanical support at all, breathing entirely on his or her own.